Welcome to the deep dive. Today, we're really zeroing in on a condition you'll definitely encounter, diverticulitis.
Absolutely. It's super common.
Yeah, and we're aiming to make this your kind of ultimate revision guide. Just the essential high-yield stuff you need for exams like the MSRA.
Strip back, easy to digest.
Exactly. We've done the heavy lifting, sorting through the details, so we'll hit, the definition, causes, risks, how it works pathologically,
What else it might look like, who gets it, the symptoms.
the tests, management, prognosis, and yeah, the complications too, everything you need. Ready to jump in.
Let's do it. So first things first, what exactly is diverticulitis?
Okay, right. So picture the colon. Yeah, that large intestine. Sometimes these little pouches, like tiny bubbles or out pockets, form in the lining. They're called diverticula.
Little herniations, basically.
Exactly. Now, diverticulitis is when one or more of those pouches gets inflamed or even infected.
Right, the itis meaning inflammation.
Precisely. Think of it like a little pocket getting blocked and then really irritated and sore. They most often pop up in the sigmoid and descending colon.
So lower left side, typically.
Typically, yeah. And just quickly on the terms, because they can trip you up, diverticulosis is just having the pouches, no symptoms, they're just there.
Often found incidentally.
Right. Diverticular disease means you have the pouches and they're causing symptoms, maybe some pain, bloating, that sort of thing. But diverticulitis, that's specifically the inflammation, the acute problem.
That's a really clear distinction. Okay, so what actually causes these pouches to get inflamed? What's the etiology there?
Well, the root cause is having the diverticula in the first place, which seems linked to weak spots in the colon wall, maybe pressure over time. Genetics and lifestyle probably play a role too.
And then the inflammation itself.
That usually kicks off when a pouch gets blocked, often by like a small bit of stool or maybe just bacteria building up.
Creates a little closed off space.
Exactly. That blockage leads to irritation, inflammation, and potentially infection brewing inside the pouch.
Makes sense. So thinking about who's more likely to run into this, what are the key risk factors we should keep in mind?
Good question. There's a useful mnemonic here, actually, think. Old NOSH. Helps nail the main ones.
Okay, old NOSH. Let's break it down.
Right. O is for older age, definitely more common over 50. L is low dietary fiber. That's a big one.
Less fiber, harder stool, more straining perhaps.
Possibly, yeah. Keeps things moving less smoothly. D, tricky. Maybe think, don't forget obesity. Especially in younger folks, obesity is a clear risk.
Right.
Then N is for NSAIDs, non-steroidal anti-inflammatory drugs like ibuprofen, and actually paracetamol use is also linked.
Interesting, even paracetamol.
Yeah. Let's use that for, smoking. Definitely smoking. Big risk factor. And S, sorry, I switched those. S is for smoking. HH could be history. Having had it before makes you more likely to get it again.
Okay, so old and HH. Older, low fiber, obesity, NSAIDs, paracetamol, smoking, history. That's useful. So let's dig a bit deeper into how it happens, the pathophysiology.
Okay, so we've got these weak spots in the colon wall, right? Increased pressure inside the colon, maybe from straining, pushes the inner lining out through those weak spots, forms the pouch, the diverticulum.
Little blowout.
Kind of, yeah. Then, as we said, something blocks the opening of that pouch stool. Undigested food, bacteria.
Traps everything inside.
Exactly. Creates this stagnant environment. Bacteria multiply, irritate the lining, inflammation starts, potentially infection sets in. And that's what causes the symptoms, the pain, the fever, the bowel changes.
But if it gets really bad.
Then you can get complications like an abscess, basically a collection of pus, or even a perforation where the pouch actually bursts, which is obviously serious.
Right, very serious. Okay, so when a patient comes in with, say, left lower quadrant pain and a fever, what else should be on our minds? What are the main differential diagnoses?
Crucial point. You don't want to miss something else. Top of the list, maybe irritable bowel syndrome, IBS. Though usually IBS doesn't cause fever or significant inflammatory markers.
Good point. The pattern of pain might be different too.
Yeah. Then inflammatory bowel disease, Crohn's, or ulcerative colitis. They cause abdominal pain, bowel changes, but often have other features, more chronic usually.
Need to consider those.
Definitely. And crucially, colorectal cancer. Especially in older patients with new bowel symptoms or pain, you have to rule that out.
Absolutely essential.
Then think about things like acute appendicitis. Usually right-sided pain, but sometimes it can mimic diverticulitis, or if the diverticulitis is right-sided.
Which can happen, though, less common.
Right. And finally, just simple gastroenteritis, a tummy bug, can cause pain, nausea, diarrhea, but again, usually less localized tenderness and less systemic inflammation than diverticulitis.
So keep a broad perspective initially. Okay, let's talk numbers. Who actually gets this? What's the epidemiology like?
Right. It's a bit hard to get exact figures for diverticulitis prevalence in the UK, but we know it's very common overall, especially as people get older.
And more common in Western countries.
Definitely. Much rarer in places like rural Africa or Asia, which points back to diet, likely that low fiber intake we mentioned.
Makes sense.
Yeah.
Any specific UK numbers?
Well, for a serious complication, perforated sigmoid diverticular disease, the incidence is around 3 to maybe 5 cases per 100,000 people per year, so not insignificant.
And just having the pouches, the diverticulosis.
Oh, that's incredibly common. Maybe 5–10% of people over 45, but it shoots up to like 80% in those over 85.
Wow, 80%.
Yeah. But remember, most of those people, maybe 75%, never get symptoms. Only about, say, 10–25% of people with diverticula will actually develop diverticulitis or symptomatic disease.
So having the pouches doesn't mean you'll get the inflammation.
Exactly. It's also pretty rare before age 40. But when it does happen in younger patients, it can sometimes be a bit more aggressive, higher risk of complications maybe.
Good to know. And any specific complications that are particularly common?
Fistulas are worth mentioning, those abnormal connections. Colivesicular colon to bladder is quite common, and colovaginal colon to vagina also seen.
Okay, that paints a good picture of who's affected. Now let's focus on how it presents. The clinical features. What does the patient typically report?
Okay, the classic symptom is abdominal pain, usually described as constant, maybe crampy sometimes, and typically in the lower left quadrant.
The L of you.
Right. But always remember that exception in some Asian patients, it can present with right lower quadrant pain. Easy exam question, that one.
Good tip. What else?
Fever and chills are really common. Signs of that underlying infection or inflammation, nausea, maybe vomiting. And often changes in bowel habit could be constipation, could be diarrhea.
Bit variable then.
Yeah, it can be. Bloating and gas are also pretty common complaints. The pain can creep up or hit more suddenly. And on examination,
What would you expect to find?
tenderness when you press on that lower left abdomen is the key finding. Sometimes you might even feel a sort of tender fullness or even a distinct mass there.
And always thinking about complications.
Always. Abscess, perforation, obstruction, fistula. Keep those in the back of your mind. Oh, and one other thing, diverticular hemorrhage.
Ah, yes, the bleeding.
Yeah, it's a major cause of lower GI bleeding. It usually presents pretty dramatically sudden, painless bleeding. Bright red blood, maroon blood, clots.
Sounds alarming.
It is, but the good news is most of the time it actually stops on its own, spontaneously.
Okay, good to know. So we have a suspected case based on the history and exam. What investigations are we going to order to confirm it and see how bad it is?
Right. Investigations are key. You'll start with blood tests, full blood count, looking for a raised white cell count sign of infection, and inflammatory markers like C-reactive proteins, CRP. That'll be up if there's inflammation.
Standard infection screen, basically.
Pretty much. Then imaging is really the mainstay for diagnosis and checking for complications.
And the best imaging modality is?
Generally, a contrast-enhanced CT scan of the abdomen and pelvis. It's really good at showing the inflamed diverticula, thickening of the bowel wall, and spotting things like abscesses or free air from a perforation.
Okay. What about ultrasound?
Ultrasound can be used, maybe if CT isn't available quickly or you're worried about radiation, like in younger patients or pregnant women, but it's generally not as sensitive as CT, especially for complications. It's quite operator-dependent, too.
Right. And colonoscopy during the acute attack?
Generally, no. Big no-no during an acute episode. There's a risk of making things worse, even causing a perforation because the bowel wall is inflamed and fragile.
Makes sense. But later on?
Yes, definitely. Once the acute inflammation has settled down, usually after a few weeks, maybe 6 weeks or so, a colonoscopy is often recommended.
Why then?
Mainly to get a proper look at the whole colon, confirm the extent of the diverticular disease, and crucially to rule out any underlying malignancy, like colorectal cancer that might have been masked by the inflammation or even mimicking it.
Okay, so CT for acute diagnosis and complications, colonoscopy later for exclusion. What if you strongly suspect complicated diverticulitis from the outset? High fever, really unwell.
Yeah, if the clinical picture is severe or the inflammatory markers are sky high, you want that contrast CT ideally within 24 hours.
Quickly then.
Yeah. If contrast is a problem, maybe kidney issues or allergies, then you might consider non-contrast CT or maybe MRI or ultrasound as alternatives, but contrast CT is preferred.
And if the inflammatory markers aren't raised?
Well, then you should really question the diagnosis of acute diverticulitis and think hard about those differentials we talked about earlier.
Good point. What about investigating specific complications, like a fistula?
For fistulas, you might need more specialized tests, like a cystoscopy to look inside the bladder if you suspect a colivesicular fistula, or a cystogram, which is an X-ray with the contrast in the bladder. Sometimes contrast enemas or studies using dye like methylene blue can help outline the tract.
And for the hemorrhage, if it's ongoing.
If the bleeding doesn't stop, you might need urgent investigations to find the source. Flexible sigmoidoscopy or full colonoscopy can sometimes identify and treat the bleeding point. If that doesn't work or isn't feasible, then maybe nuclear medicine scans like a tagged red cell scan or angiography imaging the blood vessels might be needed to pinpoint the bleed, potentially allowing for embolization.
Lots of options depending on the situation. Okay, let's move on to management. How do we actually treat diverticulitis?
Right, it really hinges on how severe the attack is. Let's start with mild, uncomplicated cases.
The ones managed as outpatients.
Often, yeah. For these patients, treatment typically involves a course of oral antibiotics, plus advice on diet, usually starting with clear liquids for a day or two to rest the bowel, then gradually reintroducing low-residue foods as symptoms improve.
And pain relief.
Yeah, simple analgesia like paracetamol is usually recommended. Avoid NSAIDs if possible, given they're a risk factor.
Okay, so antibiotics, bowel rest, pain relief for mild cases.
Yeah.
What about severe diverticulitis or complicated cases?
Those patients generally need admitting to hospital. Management there involves intravenous antibiotics, broader spectrum usually, complete bowel rest, so they'll be kept nil by mouth initially and maybe needing IV fluids.
Close monitoring too, presumably.
Absolutely. Watching vital signs, pain levels, abdominal exam, repeating blood tests like CRP to see if the inflammation is settling. And then, in some situations, surgery might be needed.
We'll come back to surgery. What about long-term management after the acute episode resolves?
The main goal long-term is to prevent recurrence. The cornerstone advice is usually a high-fiber diet.
To help keep stools soft and reduce straining.
Exactly. Plus, ensuring good fluid intake. And general lifestyle stuff, maintaining a healthy weight, getting regular exercise, stopping smoking if they smoke, all seem to help reduce risk.
Okay, let's drill down a bit more. For uncomplicated diverticulitis treated as an outpatient, what kind of follow-up?
They need clear safety netting advice when to come back if things get worse. And usually, follow-up is needed to ensure resolution and consider that delayed colonoscopy we mentioned.
And for those admitted, when might they need surgery during that admission?
Surgery might be needed acutely in about 15 to 30% of admitted patients. The main indications are complications. So perforation with generalized peritonitis, that's a surgical emergency, needs urgent operation.
Right, wash out the abdomen, deal with the perforation.
Yeah. Other reasons might be a large abscess that can't be drained effectively percutaneously through the skin with a needle, or ongoing sepsis despite antibiotics, sometimes bowel obstruction caused by the inflammation, or a fistula causing significant problems, and occasionally if you can't rule out cancer as the underlying cause.
So, mainly for complications or failure of medical management.
Pretty much. And remember that recurrence risk, about 1 in 3 people might have another attack later. Repeated attacks can also become an indication for elective surgery to remove the affected segment of colon.
How do we manage specific complications, like an abscess?
Small abscesses, say less than 3 or 4 centimeters, might resolve with just IV antibiotics. Larger ones often need draining. Usually that's done percutaneously by interventional radiology, using CT or ultrasound guidance to place a drain. If that's not possible or doesn't work, surgical drainage might be needed.
And fistulas.
Fistulas generally require surgery to fix them, to take down the abnormal connection and repair the organs involved.
Obstruction.
Often the obstruction from inflammation improves as the diverticulitis is treated. If it's due to chronic scarring causing a stricture, sometimes endoscopic dilation or even placing a stent can be considered, or surgical resection might be necessary.
And hemorrhage management.
Initial resuscitation is key IV fluids, blood transfusion if needed. Then, as we said, try to find and stop the bleeding, usually starting with colonoscopy for potential clipping or cautery. If that fails, angiography with embolization is an option, basically blocking the specific bleeding vessel. Surgery, like a colectomy, is usually a last resort for refractory bleeding.
Okay, comprehensive approach. When should we be thinking about referring a patient to a specialist, say, in primary care?
Definitely refer for same-day assessment in hospital if you suspect complicated diverticulitis, severe pain, signs of peritonitis, systemic sepsis, significant dehydration.
Urgent admission.
Yes. Also, consider referral if there are features that might suggest inflammatory bowel disease instead, or if the patient meets the criteria for an urgent suspected cancer pathway referral based on their symptoms and age.
Makes sense. So, moving towards the end, what's the likely outcome for patients? The prognosis.
For most people with uncomplicated diverticulitis, prognosis is actually pretty good. Symptoms usually get much better within a few days to a week with treatment.
That's encouraging.
Yeah, but that recurrence issue is real, and some people do go on to have further problems or need surgery eventually. Remember, for those with just diverticulosis, the pouch is without inflammation, about 75% stay completely symptom-free.
And the serious problems.
Most of the really serious complications tend to happen during the first attack of diverticulitis. Overall morbidity and mortality are linked to those complications: perforation, sepsis, major bleeding, but it's relatively low overall considering how common the condition is.
Is it worse in younger patients?
It used to be thought so, but recent evidence suggests morbidity isn't necessarily worse just because they're younger, although complications can still occur.
And prevention, we touched on diet. Anything else?
High fiber intake seems to help prevent developing diverticular disease in the first place. Whether adding fiber after you already have diverticula prevents itis is maybe less clear, but generally still advised.
Okay.
Physical exercise definitely seems protective. Maintaining a healthy weight helps. Quitting smoking is beneficial. Basically, a healthy lifestyle seems to reduce the risk.
Good general advice anyway. Okay, and just to quickly recap before we finish, what are those main potential complications again?
Right. The big ones to remember are abscess formation, that collection of pus, colon perforation, the bowel bursting, fistula formation, those abnormal tunnels to other organs like the bladder or vagina, bowel obstruction, the colon getting blocked, and peritonitis, severe inflammation of the abdominal lining, usually from a perforation.
Got them. Abscess, perforation, fistula, obstruction, peritonitis. A clear list.
That really covers the spectrum of diverticulitis. And that wraps up our deep dive on diverticulitis for today. We've gone through the definitions, risks, how it happens, how it looks, how we investigate and manage it, and what to expect. Hopefully that gives you a really solid, high-yield overview for your revision.
Remember that old NOSH mnemonic for risk factors and the importance of CT in the acute setting, but colonoscopy later.
Absolutely. Keep pushing forward with your studies. You're doing great.
Yeah.
And don't forget, for loads more helpful resources designed specifically for the MSRA and other medical exams, check out passthemsra.com.
And there are free resources available too at freemsra.com. Definitely worth a look.
Definitely. Thanks for joining us on the deep dive, and we'll catch you next time. Keep learning.